Good morning. I'm Dr. R. Dukmajian, CEO and founder of the Duke Spine Institute. I'm here with a patient who traveled here from Michigan. He's had 8 years of chronic debilitating neck pain. It's totally destroyed his life, and he's here today at Duke Spine Institute to have our Duke laser disc repair procedure to fix 2 disc herniations. They're small, they're bulges, they're clear tears in the posterior annular wall with the herniation of the nucleus, and I believe they're the source of his pain. It localizes exactly to C4-5, C5-6. His pain does on examination. That's where he points his pain is. He doesn't have any facet joint pain. I had him rotate his neck side to side, no pain. And I believe we're going to be able to get in there and fix these 2 discs. Now, he does have some bone spurs in the front of the spine. We're not interested in those except to get past them. You can see on the x-ray, Jordan is highlighting 2 of the bone spurs. One is at C5, the other at C6. You guys see that?
Yes, we do.
All right. Patient is intubated under general anesthesia, completely asleep and relaxed. I'm on the left side of his neck. He is looking up at you under the drape. So here we go. I feel the bone spurs. We're going to try to get into C5-6 shot. If you have questions, feel free to ask us, and I'll do my best to answer. Shot. All right, AP. AP is a front-back x-ray. We use lateral and AP x-rays to navigate and localize. Perfect, thank you. Oh, here we go. I'm going to advance my needle down to C5-6 first. And once we're done at C5-6, AP, we're going to move up to C4-5. We got 2 discs to fix today with our Duke laser disc repair. For those of you, perfect, we're in the middle. I like that. For those of you who have never watched this surgery or don't know anything about the Duke laser disc repair, it is a peer-reviewed, published procedure that does not involve fusion and shot. Yeah, we're definitely bumping against some of the bone here. I just got to get past it. A lot of times these osteophytes are not thick, but they do create a barrier to entry through the front of the disc. AP. So I'm moving my needle along the front of the spine, trying to find a nice opening between the bone spurs so I can get in there. All right, that's pretty much the middle. And if I can't, that's okay too. We have a strategy to deal with that situation as well. All right, I'm going to try a little bit more, see if I can just get in. Shot. If you have questions, feel free to ask us. We will try to answer your questions for you during the surgery. Surgery should take about 40 minutes.
We have a question.
Shot.
Coming from Lanu on YouTube.
AP. Hi, Lanu. Good morning.
Asking, herniation on C5, C6, and C7 are very common. Have you ever seen a herniation on C1?
Great question. There is no disc at C1, so there can't be a herniation. C1, C2 is not possible to have a herniation. All right, so at this point, I'm going to have to go through the bone spur. To do that, let's see if I can try one more time. Nope, I'm just encountering spur the whole time, no matter where I go. Okay? All right, so to do that, I'm going to first put in a guide wire, and then we're going to numb up the skin. We're going to make a 4mm incision. Can we have a new guide wire, please? I'm going to numb his skin in the front of his neck. Yep. So C1, C2, shot. Occiput C1 and C1, C2 do not have discs. All right, here we go. Let's just check our AP one more time. Go ahead. AP is front back. I want to make sure I'm pretty close to the middle. I like the lateral view. I could be a little bit more towards the middle. So let's make an incision. All right, I just made a 4mm incision. That's big enough to place our dilator and our tube. I'm going to hold my guide wire against the front of the spine. And I'm going to bring my shot. Nope, we slipped. So we're going to have to reposition. So what happened is the guide wire has literally slipped to the side of the spine. We don't want that. Let's have the needle. I'm going to place the needle right back through the same incision I just made. The good news is his neck is very supple, meaning shot, meaning that I'm not fighting his muscles. Shot. All right, let's go with an AP. I want to verify I'm in the midline. So you use a front-back X-ray AP to verify you're in the middle, which that is. It's perfect. And then you use a lateral view to see how deep you are. So you have to use both views, AP and lateral. Hold on. Any other questions? Actually, we're in
Yes.
this time. We made it in. We got around the bone spur.
Yay.
Oh, yeah, yay. Yay is right. All right, so we'll do a quick discogram, and then we will start the actual surgery. I got a little bit of luck there. I kind of got it around the bone spur by going where the mouth of the bone spur is. You can see there's a bit of a mouth there. All right, here we go. Everybody agree we're doing number 5-6 and 4-5. Massive bone spurs. He must have had a pretty bad injury to this disc. Shot. There you go. Look at the tear in the back of the disc. Jordan, show us that tear. See how the dye leaks out through a tear? You can see the black dye leaking out. And then there's a herniation there. That is our target. We want to clean that tear. That will get rid of his neck pain. All right. Henry.
Yes, sir.
We talk about neck pain, and the audience should know there are about 30 different causes of neck pain.
Yes.
They're really related mostly to joints that have been damaged over time, and they develop arthritis in the joint. So let's show the audience the 30 different common causes of neck pain.
Of course.
I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. We're going to talk about the 30 causes of chronic neck pain. Chronic neck pain is neck pain that lasts longer than 6 weeks. There are 30 causes to chronic neck pain. The most common cause is the disc. There are 6 discs in the neck. These discs can become injured. The first disc is C2-3. Next is C3-4, C4-5, C5-6, C6-7, and C7-T1. The most common disc to be injured and cause neck pain is C5-6, followed by C6-7, followed by C4-5. The other discs rarely cause pain. Discogenic pain represents 85% of chronic neck pain. Next, the facet joints cause 10% of chronic neck pain. Facet joint pain is very common in patients with neck injuries and spine injuries. Facet joint pain is usually located on the sides of the spine, either right, left, or both. Facet joint pain gets worse with rotation of your head and neck, worse with extension. The most common facet joints to be injured are C5-6, C6-7, and C4-5. C7-T1 is another common facet joint to be injured. These joints, after injury to the capsule, will develop arthritis. It is the arthritis in and around the facet joint that causes the neck pain and stiffness with movement. Duke plasma rhizotomy is the best treatment in the world available for painful facet joints. Duke laser disc repair is is the best treatment in the world available for painful discs. Other causes of chronic neck pain include fractures, tumors, infections, and muscle spasms. These other causes represent less than 1% of chronic neck pain. Thank you for joining us for 30 causes of chronic neck pain. Okay, welcome back. You can see from our video there are 30 common causes of neck pain. The most common is the disc injury. Disc injuries account for about 90% of chronic neck pain, 90%. 90% of patients with chronic neck pain, the disc injury is the primary cause. Right now I'm advancing watch that tip. I'm advancing the tube down the dilator. You guys see that?
Yes, we do.
The dilator tip is moving a little bit. I'm not happy about that. I'm going to have to pull the dilator back a little bit just to be safe. Hold that. All right, I need something to grab it and pull it back a little bit. You want me to use this? Any questions, Henry? But before we take questions, actually, I do want to draw the audience's attention to the most common cause of neck pain, which we've just talked about, the disc, a disc injury. So for those of you wondering, what is a disc injury? What is a disc? A disc is the cushion between the bones. As a matter of fact, we are inside the disc right now. The number 5, 6. Jordan, count for us to show us the numbers. Shot. 2, 3, 4, 5, 6. So we're at the 5, 6 disc. Shot. Yeah, gotta have to pull the dilator back again. Go ahead. And the disc is by far the most common cause of neck pain, and the injuries can be a herniation. That's good. That's fine. That's fine. Can be a herniated disc, a bulging disc, a ruptured disc, a slip disc, a protruded disc, an extruded disc, a degenerated disc, a spondylitic disc. All of those things are possible injuries that cause neck pain. Okay? And they're all really the same thing. They're all part of the degenerated disc cascade. So all your degenerated discs start with an injury called an annular tear. Once you get an annular tear, then you also get herniations through the tear. So it always requires trauma to get the annular tear. There's no other way, There's no other way to get an annular tear. You must have trauma. Trauma causes the annular tear, and at the same time, the trauma crushes the nuclear material next to the tear. So in the back of the disc, for example. Once you crush the nucleus into pieces, they're called fragments, you get fragmentation or pieces, and then those pieces start to work their way out of the tear over time. And that's what we're dealing with. That's what a herniation actually is. A herniation is pieces of nucleus, fragmented pieces of nucleus next to the tear, just inside of it, that eventually work their way out through the tear because of lifting, twisting, sports, any kind of normal activity you do with your arms and your neck. And when you get enough of those pieces out in the tear and beyond, they cause symptoms such as neck pain, arm pain, weakness, numbness, and tingling. And that's what our patient is suffering with, neck pain. So let's show the audience why disc injuries cause so much pain.
Disc injuries start with an annular tear. Damaged nucleus pulposus herniates into the annular tear. The herniation triggers an inflammatory response within the annular tear. The inflamed annular tear generates pain signals. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
So in the animation video, you can see the inflammation of the annular tear is the cause of the neck pain. There's the inflammation. It's that orangey pink stuff. That's evidence of inflammation right there. There's a piece of herniation coming up. So what we do is we use this 0.5 millimeter, 0.5 millimeter laser fiber to direct laser energy to the tear, right where the herniations are scarred down to the tear. And we release these pieces of herniation up and out the tube, and that gets rid of the neck pain. And it's a permanent fix, by the way. Unlike shots, unlike other types of treatments for people, this is the only permanent fix to the neck pain. The fusion would be another option, but who wants a fusion, right? Who wants metal in their neck? Who wants all the risks of fusion surgery, the long recovery, the complications, the adjacent segment disease? You know, they published that the complication rate for fusions in the neck is 50%. That's 1 out of every 2 patients will have complications. That's horrible. We've never had a complication with Duke laser disc repair. 20 years of doing this surgery, not a single complication. I've done about 1,000 cervical Duke laser disc repairs, pretty close to 1,000, and I've not had a single complication. That's 1,000 patients, by the way, not 1,000 discs. If you look at how many discs I've done, it's close to 2,500 discs, probably just around 2,000 discs, because we do an average of 2.4 discs per patient. In other words, the average patient with neck pain that comes from disc injuries has 2.4 discs per patient that cause their neck pain. Now, everybody knows you can't have a 0.4 disc causing neck pain, but that's the average. That's what happens when you do averages. You get fractions, okay? Whole numbers with fractions. So that's what we've got, 2.4. By the way, this is the herniation. You can see that in the back there, that is the what's called the posterior longitudinal ligament, okay? So we're at the back of the disc. We're not taking his disc out. We are only taking out the herniation and the scar tissue and the inflammation. We're leaving his disc there. That way he doesn't have to have metal put in his neck. He doesn't need a cage. He doesn't need an artificial disc. The only reason doctors put artificial discs in your spine is because they go in and take the whole disc out. And the reason they take your whole disc out is, number one, they don't know how to do this type of surgery. They've never been trained. This is the newest type of surgery in the world for spine. It is the most advanced. So if you don't know how to do this type of surgery that I'm doing right now, then your only choice is to take the whole disc out to get to the piece in the back that's called the herniation, okay? And that's what I was trained originally to do 27 years ago, was to take the whole disc out. We use a microscope to do that, and to take the herniation out behind the disc, and then to put a cage in there, either bone cage, plastic cage, metal cage. Those are the 3 types of cages, or an artificial disc, which is a combination usually of metal and plastic. So for years, that's what I did. I did what every other spine surgeon does, is fusions, and I thought that was the best treatment until I learned from the Koreans how to do endoscopic surgery, this exact surgery, transdiscal surgery, and then I added the laser to the procedure with the debridement, which is what I'm doing right now. You see how I'm cleaning this stuff with the laser? That is called the annular debridement. That is what I pioneered and discovered. I published about 13 years ago, even longer than that actually, about 15 years ago. And so here we are doing the same surgery for 20 years that I published 15 years ago. And it works. It works amazingly well. And there's no need for metal or fusion or hospitals or bleeding. We lost about, maybe 1 ml of blood, which is about 20 drops of blood when we started. We're not losing any more blood right now. There's no scar tissue that we're creating with the surgery. The pain from the surgery is minimal to none. Basically, he'll have no pain tomorrow when he comes in and checks in with us in the morning before he heads back home to Michigan. All right. Before we take our questions, we'll do one more video. Henry, since
Yes.
we showed the audience how these tears and herniations, disc injuries cause neck pain, let's show them what we're doing here with the Duke laser disc repair to fix it.
Of course.
Disc injuries is a common cause of chronic neck pain. The inflamed annular tear causes neck pain. A 4 mm skin incision is made. A small tube is inserted with no damage to the bones or soft tissues. The laser removes herniated disc fragments and debrides the posterior annular tear. The annular tear heals on its own after the procedure, which can take up to 12 months. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Well, I hope you enjoy that video. That is how we fix these herniated disc, bulging disc, ruptured disc, protruding disc, extruding disc, prolapse disc, slip disc, degenerated disc, spondylitic disc, okay? It's a mouthful, but they're all the same thing, basically. You start with an annular tear, you get a bulge, then you get a herniation. The herniation has many different names, depends on who you ask, but doctors, for some reason, felt like they needed to come up with 20 names for the same thing, herniated disc. So I didn't create all the names, somebody else did. I guess for some reason they felt compelled to do that. I don't know why. I mean, cheese is cheese, a car is a car. I guess you could call a car an automobile as well. But, you know, only when it comes to discs and their injuries do we have literally 15 names for the same thing. I don't think there's anything else in the world that has 15 names for the same thing. Even Satan, right? You have the devil, you have Satan, you have Beelzebub. I mean, how many other names does Satan have, Henry?
Lucifer.
Lucifer, that's a good one. So that's 4. How many more? So maybe Satan has 5 names, right? Even Jesus has names. Yahweh, Jesus Christ.
Adonai.
Huh?
Adonai.
Yeah, so Jesus has 5 or 6 names. Satan has 5 names or 6 names. But the disc herniation has 15. Why? You ever think about that? Why? Why does the same one thing have so many damn names? But there's nothing else in the world that has that many names for one thing. Huh? All right, let's take some questions.
Next question coming from Gary on YouTube.
Yeah, Dr. Berndes mentions that's so challenging, you know, what a problem it is. All right, Gary, let's hear from Gary on YouTube.
Gary asking, morning, just wondering, do you always enter through the front of the neck when doing neck laser disc removal? Amazing work.
Yes, thank you. Yeah, first of all, we're not doing a disc removal. We're doing a disc repair. We don't remove the disc, we're repairing it. But yes, it has to be done through the disc. That is the only way to get back to where we're working right now and do what we're doing right now. You cannot go through the back. Going through the back doesn't work very well. It's called a foraminotomy, laminectomy, foraminotomy. I don't recommend it for patients with primary disc problems unless you can't get to it through the front for some other reason. But the best way to fix these disc problems is through the front. That's the only way. By the way, all these little white things are herniations that I'm floating out, right? I'm releasing them with the laser, and then I'm floating. There's a piece of herniation, and then I'm floating them out. This is a newer piece of herniation, probably about a year old, based on its architecture, what it looks like. Okay, that's a newer herniation. Remember, a herniation is not a single event. It's a multiple event. It happens with multiple events, multiple pieces being herniated over time, over years. All right, every time you have a flare-up of neck pain, that's another herniation that you just pushed out. And that's causing the inflammation to go up and cause pain. So every time you have a flare-up, it's another herniation. Okay, that's how it works. Nobody in the world ever discovered that until I did. Now, the reason I was able to discover it is because I do endoscopic surgery, like you're watching right now. You can actually see all the herniations, and more importantly, you can see how old they are. They're not the same age. Some of them are young, like a year old or less. Some of them are older, like 20 years, and they look different. They have a different appearance to me under the endoscope. Okay, so that's why I know, my God, look at that. We're just blasting that piece of herniation, literally 0.5 millimeter at a time. We're almost done with this disc. I've got to go check the other side. That was the foramen, by the way, on the left C5-C6 foramen. We're going to the right foramen, big herniation here, all scarred up. We're going to whittle away at it and get rid of it, a little bit at a time. All right, what other questions do we have?
Next question coming from Lanu once more on YouTube.
Hi, Lanu.
Asking, does this patient have numbness on their hands?
Does this patient have numbness? I'm going to have to defer to my staff to look at the chart. No numbness. They didn't complain. Huh? Yeah, pain. He has weakness, severe pain in the neck, weakness. Huh? Yeah, he has weakness in his shoulder area because this is a higher herniation, right? L4-5 is a higher herniation. It pinches the L5 nerve root. That's the first nerve in the brachioplexus. I'm sorry, L5. I meant C5. I apologize. C5 nerve. Any other questions, Henry?
Yes. This next one is, I believe this is a question and or seeking advice from Imran on YouTube.
From Imran.
Imran, I believe, from Pakistan.
IMRAN?
IMRAN.
Oh, Imran, do you work on our website?
Imran
Right.
asking, I have a problem in my C5 and C6 and C4,
Yes, Imran.
and also an Atlas C1. Herniated disc 2. Some different doctors said to do surgery, some said to do physiotherapy, and so on.
Yeah. All right, so Imran, first of all, your C1, C2 is fine. There's nothing wrong with it. The only doctors that talk about C1, C2 and try to tell the patient there's a problem they're chiropractors. So I'll bet you anything it was the physiotherapist who told you C1, C2. There's nothing wrong with your C1, C2. I have treated C1, C2 for 20 years, and the C1, C2 is almost never, ever, ever the cause of problems. It's your herniations. So my advice to you is to come to Florida and let me fix your neck. That's your best chance of getting rid of your pain. All right, that's my advice. Come to Duke Spine Institute and let us operate to fix your problem. But before we do that, we have to do an MRI review. And by the way, it's free. We don't even charge you for it. It's 100% free. All right, this is the last of the herniation, the deepest part. You see that? And
Yes, we
it's
do.
a gold color because it's full of calcium. The only way you get this much calcium or bone spur in the herniation is when you have a really, really old herniation. And by the way, it's no wonder why this poor man has suffered for so many years of pain in his neck. All of this stuff is abnormal, but it comes from chronic inflammation, okay? Chronic inflammation. He has clearly had a problem. It's been ignored by the doctors where he lives. The doctors had no idea how to fix it, just like I hear all the time. The problem was the herniation causing inflammation. We're done with this disc. I'm just going to move on. We're going to irrigate out these pieces. We're done here. We've cleaned out as much of the herniation as we can. That should fix this problem. So one disc down, one more to go. Scope off. I'm going to put some antibiotic. Just kind of clean things out. Keep the questions coming. Dilator.
We have a few more questions. This next one is coming from, excuse me if I mispronounced the name, Pavel on YouTube.
Hi, Pavel.
Asking, hi doctor, it's amazing to watch your surgery. Are you teaching your technique to other surgeons, or have you had other neurosurgeons approach you to learn your technique?
That's a great question, Pavel. Great question. So I am teaching. I'm teaching through YouTube, through live streams. I have offered for other neurosurgeons to come, but here's the problem. In America, the surgeons don't want to do this surgery. Why? Because it doesn't make them as much money as fusion or artificial disc. For example, when I was doing fusion, I would make 10 times or 20 times as much money as I make here. 20 times. So surgeons, unfortunately, want to do the procedures that make them the most money, so they're recommending fusions for the patients. I, on the other hand, made a lot of money doing fusions for the last 20 years, and now I'm shifting my focus away from myself and taking care of me, but more my patients. I want my patients to have the best treatment, even though it means I make less money. The problem is most surgeons won't do that. So they're not interested in learning this technique because, number one, it's very hard to get paid and make money doing it. And number two, it's very hard to do. They don't know how to do this. You have to have special equipment. And the equipment takes $10 million to buy. All right, we're going to move from C5-6 up to C4-5. But I have some hope because my son wants to be a neurosurgeon. And he is currently at Princeton. And I'm hoping that he's going to come here and take over and do the surgeries and let me just focus on diagnostics, shot, and training. And I will train surgeons while he runs the company. So I will be training surgeons more over the years as we have the volume and the need. I need a Raytech first. Okay, this is very special. I was the first in the world to do this next move. It is moving from one disc to the next, and it's called the Duke Spine Slide. The Duke Spine Slide. We are literally sliding along the anterior longitudinal ligament just in front of it, sliding the tip of the dilator to the next disc, either up or down. In this case, it's up. Everyone agree up? Yes, C4-5. Shot? All right, so to do this, I have to come out of the disc and slide up to the next one. This is called the Duke Spine Slide. When I learned endoscopic surgery from the South Koreans, from Dr. Sang-Ho Lee, Dr. Gun Choi, many years ago, they only did one disc at a time, and I was the first in the world to do two, even three. Damn. All right. And I took my technique, and I've been teaching it over the internet to people that are interested for the last 10 years. I've been teaching it on the internet. So, shot. All right, I've got to figure out where we are. Are we to the left, to the right, center? So I need to get another x-ray real quick. And ready? Tell me when you're ready. Ready. Shot. So I'm off to the right. I need to come back to the middle. Whoop. Shot. I think I went back in the disc. Shot. Yep, I went back in the disc. Lateral. So because of the bone spurs in the front, it's kind of pushing my dilator around. It's making it difficult to navigate the tip. Shot. Yep, we went back in the disc just as I thought. I could feel it. So I'm going to come out again, and this time I'm going to go up and try to, but this bone spur is like a mountain I'm trying to climb over. And right there I'm out, and now I'm in the front again, and I want to see where we are. Shot first. Yep, okay, good. AP. Now my goal is to stay right on the anterior longitudinal ligament. I have about 1 centimeter left and right of midline. All right, that's good. Stay there for a second. I'm just going to move north. Worst case scenario, I just have to place the needle again. Shot. All right, so let's go to a lateral view. So what's happening is his bone spur in the front of the spine is pushing my dilator around and making it difficult for me to go where I want, but I will eventually get to where we need to go. Shot. Shot. Is his head straight up and down? Shot. That's better. Keep it straight. Shot. All right, we're making some progress. Shot. Perfect. Now AP. I need to check that, make sure that the tip of my metal instrument is in the middle again. It looks like it is, but I have to check. There it is. So we're in the middle. That's perfect. So I'm literally resting the tip of the dilator right along the anterior longitudinal ligament. I'm not taking it off. It's very important we don't take it off. I'm going to try to get a little bit more north. Shot. Shot. All right. I felt it slide to the right. Shot. I think that's as good as I'm going to get it right there. Let's get one more AP. Never push your dilator into the disc without verifying that it's in the front, in the middle. Shot. That's perfect. We're dead center. I love it. Go back to a lateral view. So I'm very happy. Don't move the neck. Just keep it tight in line. Shot. So we slipped down a little bit. See that? I've got to move back up. Shot. All right. So there we are. Shot. Shot. All right. Now let's check AP again. Any questions?
Yes, we have a few questions. This next one coming
Perfect.
from Mary on YouTube.
Mary on YouTube. Welcome. Shot.
Asking, what do you recommend to have the bone spur removed?
We don't remove bone spurs like that. It's unnecessary. No reason to remove it. Everybody thinks bone spurs need to be removed. They don't.
Next question is coming from Gary, once more on YouTube.
Shot. Gary?
Asking, will the herniated disc in the neck cause severe stiffness and, of course, the pain down the arms and headaches? Also, I have an MRI from May last year. Do I need an updated one?
No, May last year is fine. Okay, look at this, folks. This is important. I am pushing really hard to get the dye out into the disc. It's not going. Barely any is going. What does that tell me? It tells me that the disc is full of scar tissue. Okay, a normal disc will let the dye go in easily. But here I'm pushing as hard as I can and I'm barely getting any of it out. Why? Because the disc is literally full of scar tissue. But you can still see there's a double tear, a double annular tear, one at the top, one at the bottom, top, bottom, and then you can see the herniation behind. Yep. So very, very full of scar tissue, very abnormal disc, C4-5. Okay, here we go to the back. Yeah, your May MRI is fine to do the MRI review. And yes, a disc problem can cause neck pain, stiffness, arm symptoms, radiating into the shoulders. Absolutely. That's probably what's causing it, but we will want to examine your shoulder as well to make sure you don't have a shoulder problem. Shot? Okay, you can see the tube is coming down, and now we're going to advance the tube into the disc, and we're going to put the tip of the tube at the back of the disc where the tear and herniation are. Shot? All right. So we're going to watch very carefully. Shot. Lots of shots. Lots of shots. All right, let's see here. All right, dilator came back a little bit. Came back a little more. Shot. It's okay. As long as my tube is sliding over the dilator, now it's not okay because the dilator came back too far. We're going to re-advance it. Come on, Jordan. All right, there we go. Re-advance dilator. Slide the tube over the dilator. It may come back again. All right, this is happening because there's a lot of pressure at the back of the disc from inflammation. Almost done. That was a good one. I think that's about it right there. Perfect. I'm happy with that. The tip of my tube is right at the back of the disc, right where the tear and herniation are. We're going to use the laser to remove the herniation and clean the tear. Again, Duke laser disc repair. Any other questions?
Yes, we have a question coming from Lanu once more on YouTube. Asking a question for Henry. Do you keep track of viewership on every live stream? The statistic is very important. Let me tell you this, Lanu, as much as I do keep track of the viewership, it's more on the engagement and the impressions that I really focus on because we want to reach out to anybody, not only for people to reach out, but also for them to reach back to us. And so with today, we've had a very, very good engagement with everybody, with you guys. And so as grateful we are with that, that is the main focus here. But I understand that viewership is also very nice to have as well. So, but it's more of engagement that I really focus on the statistic of.
Yeah, I would like to say something.
Of course.
About viewership. I think it's sad, very sad, that our viewership is not higher, because
Agreed.
this problem is something that millions and millions, actually worldwide, hundreds of millions of people have neck pain and back pain. The number actually is close to 1 billion people worldwide have neck or back pain, or both. And that's chronic. Chronic means it's more than 6 weeks, and it's significant, right? There's a herniation right there. You guys see that? It
Yes,
came
we
out
do.
of the foramen. That one is probably about 3 years old. Now, you could see it was sitting down there pushing on the spinal cord. Why is it so sad? Because these social media networks like YouTube, Facebook,
Twitter.
or X,
Yeah.
they should be promoting what we're doing, because it's for educational purposes.
Yeah.
We don't charge for it. It's not money making. Oh, look at all those pieces of herniation coming out. All those were herniations sitting on the spinal cord.
We see them.
Yeah, it's amazing. But it goes again to what I said, is that a herniation is not one piece, it's many pieces. So it's sad that, because I won't pay, I refuse to spend money to promote these videos, because I'm already spending a lot of money to make them available to people to learn. And I can't, number one, I can't afford it. But number two, I don't think it's right that I should have to make this content and I should have to promote it. Okay? So it's sad that Facebook, YouTube, X, that they don't promote this material, because it is educational and it's so important to so many people, and they need this, they need to hear this, And all they do is they just want to make, these platforms just want to make money, so they'll only promote advertisements that make money for them, that people that pay them. And I refuse to do that. I'm not going to do it. So if somebody wants to donate money for the cause of promoting these videos so more people will watch it, will have a higher viewership, fine, do it. I'll put the money towards it. But I don't have a budget to promote these videos, and I don't think it's right that I should have to promote these videos. I think that these social network platforms should promote them and put their own advertisements on, not make me have to pay them.
I 100% agree with
yeah.
that. Yeah.
So yeah, it's sad that we don't have more viewership. Of all the medical problems out there, neck pain and back pain is the most common by far. It's the most important for the world, because so many people's lives are destroyed by chronic pain like neck pain and back pain. And they're looking for information, and we have that information. We offer a free service. It's educational. I answer questions. 5 minutes, Berndes, 5 minutes max. Berndes, 5 minutes max. I'll be done in 5 minutes. That's what I'm telling my anesthesiologist, so he can start winding down the anesthetic, so we can wake our patient up and get them to the recovery area. Any other questions?
No current questions. We do have two comments. One from Gary, once more on YouTube, saying, "You have a heart of gold. God bless you and your amazing staff."
Hey, thank you so much. Actually, I love the compliments, so I'm not going to lie. Who doesn't love to be complimented, right, when they do something good? So my staff and I appreciate your sentiments. Thank you so much. It means a lot to us. Nothing makes me happier than people who are happy and not suffering anymore. And that's what we just want to get the word out. So yeah, I think it's sad that their viewership isn't better. I think we should have a much bigger viewership, but I'm not going to promote it and pay for it. I can't afford to do that. These people already have to pay enough money for the surgeries, and I don't want them to have to pay for me to promote these videos.
And the next comment we have from Mary, once more on YouTube, saying, "I promise to share this video."
You're the best. Thank you so much. So we live stream our surgeries every week on Tuesday, Thursday. That's the days that I do surgery. We don't always have surgery. So the days that we don't have surgery, you won't find us. And some of our patients don't want live streaming. We always ask, we always get permission. If they say no, then we don't. And we respect our patients' wishes. We will not live stream a surgery when somebody doesn't want it live streamed, okay? So that's the only time you won't see us, is if we don't have surgeries or the patient requested no live stream. There is one other condition. That's when we have a lot of surgery and we're doing some of the surgeries in another room, room 2. Room 2 doesn't have a video camera. We cannot live stream it. So actually those are the 3 circumstances where you won't find us on a Tuesday, Thursday streaming. Duke Spine Institute has literally been streaming surgeries for 10 years. 10 years. And we've been streaming thousands and thousands of spine surgeries. You can actually watch fusion surgery on our channel. I've done so many fusions in the neck and the back. They're all on YouTube. We have hundreds and hundreds of fusions. That was more in the past, you know, we don't do as many now. We do have a fusion next week. The patient is a workers' comp patient from California, and he is having a lumbar fusion and a piriformis release. That's next week, correct, Luis? So we're planning on doing his surgery next week. If you want to watch an L5-S1 fusion, I still do them when I need to. But that's what the insurance company and the patient wanted. So we do fusions very rarely, but we still do them occasionally. All right, any other questions?
At this moment, no current questions.
I'm just about done. I've got about 3 minutes left. So I think we've shown all of our videos. Why don't we show the audience what facet pain in the neck looks like and how we fix it?
Of course.
Facet joint injury is a common cause of chronic neck pain. The inflamed facet capsule tear generates pain signals. The best treatment for facet joint pain is the Duke plasma rhizotomy. The inflamed facet joint pain nerves are destroyed. The advantages with the Duke plasma rhizotomy is that it's an outpatient procedure that takes 30 minutes to complete, very minimal bleeding and pain after the surgery with immediate recovery and return to work the next day, as well as a 99% success rate and permanent pain relief with a single treatment. For more details, please visit our website at www.dukespine.com or call us at 1-800-FIX-MY-NECK 349-6963.
Okay, welcome back. You can see the second most common cause of neck pain, that's chronic neck pain, is actually facet joint arthritis. That's what that video you just watched was. And of course, there's a new way to cure that pain where we never had the ability to cure it before, we now do. And that's called the Duke plasma rhizotomy. All right, for those of you watching the surgery, take a look here. This is the chin. His face is looking up at you. His chest is here. We're on the left side of the neck. The whole surgery was done through a metal tube that I'm going to pull it out so you can look at it. It's right here. You guys see that?
Yes, we do.
All right. So that's a 4mm tube. And that means since the tube is only 4mm wide, the whole incision is 4mm. Now, what's different about this surgery? We're not cutting any structures under the skin. So other surgeons will cut your muscles. They'll cut your tissues, your soft tissue, your connective tissue. And that's why people who have fusion surgeries have so much pain, difficulty swallowing, difficulty breathing, difficult with their voice, because the surgeon has literally destroyed everything under the skin, and that's why they take narcotics. Our patients take no narcotics because we're not destroying anything. The only thing we're cutting is the skin, and there you go. That is a 4mm incision. Okay, no bleeding. We lost 1 milliliter of blood the whole surgery. We're done. And he's going to go home in an hour. That's how amazing the surgery is. No metal plates, no cages, no artificial discs, nothing unnatural in your body. Just repair the disc and get out, go home, and get on with life. That's what we offer. Nobody else in the world does it like we do. We have more experience than anyone in the world doing these surgeries. And we can do it for the back, the neck, the thoracic. So, thanks for joining us. If there's no more questions, we'll end our stream. We'll be back in about 30, 40 minutes for another cervical Duke laser disc repair. That patient is coming from Canada, and he's traveled a long way to get here, and we're fixing a herniated disc in his neck.